Hello, and welcome to CRPS Contender, my complex regional pain syndrome education channel. Today's video is Microvessel malfunction, Ischemia-Reperfusion injuries, and traumatic vasospasms, an overview of Coderre's hypothesis. This video is based on two different papers by the same head researcher at McGill University who has a PhD in medicine. Complex regional pain syndrome type 1, what's in a name? And a hypothesis for the cause of complex regional pain syndrome type 1 reflex sympathetic dystrophy, pain due to deep tissue microvascular pathology. Both of these papers were written by Terence Coderre, and the second paper also had the additional help of Gary Bennett. Both of these papers were published in 2010. Now, while I am going to be presenting this hypothesis to you, I do want to be clear that I, personally, CRPS Contender, do not 100% agree with this hypothesis. I think it has a lot of good content. I think it is definitely worthy of consideration. I think we can take a lot of aspects from this and apply it to a more broad hypothesis. However, I am not 100% behind this hypothesis, but I will be presenting it as they wrote it. I am also, on my source sheet, not going to support their position. They have very long bibliographies in their papers. If you want to check out the supporting evidence that they have presented in their papers, you can do that on their direct published articles. I have those linked in my description. However, the stuff on my source sheet is going to be information that can help give a broader understanding of some of the concepts that they talk about, because this is written by medical professionals for medical professionals. So it can be very difficult to understand if you don't have a lot of medical knowledge and background. So my source sheet personally is going to be stuff to help explain things that they talk about in their paper that you might not understand. Before we get into their stuff, I do want to talk a little bit about some basic anatomy and physiology that's going to be important to understand in the context of this paper, that if you aren't sure how that happens, this paper will be very confusing for you. So if you are listening to this and not watching the screen, please pay attention for the next 2 or 3 minutes to the screen, because I've got some photos on here that will hopefully help this make a lot more sense. So the first thing we need to talk about is your circulatory system, and we're going to start with your heart and lungs. This is where you get fresh oxygen and the propulsion so that the blood can go throughout your body. Once your blood leaves your heart, it gets put into your arteries. Specifically, conduit arteries or elastic arteries. These are your very large vessels, and they can expand and contract with the pulsation of your heart. This carries oxygenated blood away from your heart towards your other systemic areas. Then your arteries branch a bit and become a little bit smaller, and these are known as distributing or muscular arteries, and these branch into tissues for delivery. And then you get even smaller, and these become arterioles, which direct blood into capillaries. And then the capillaries, which are microvessels, connect your arteries to your veins. Now, if you're looking at your photo here, the red side on the left, that would be an arteriole. The purple net in the center would be a capillary. And this capillary is a very thin, very small area that allows things to cross outside of your vessels into the surrounding tissue, which is how oxygen makes it to your tissues. You'll see these little white egg-looking things that are your tissue cells, and then you can see all the white space around it. This is known as the interstitial space, which holds interstitial fluid, which is usually blood plasma. So, fresh oxygenated blood comes out of your arterioles into your capillaries, perfuses the tissue, and then some of that fluid in your interstitial space gets picked back up by the capillaries and moved into your venules, which go into your veins. And this uses a valve system to work against gravity and carries deoxygenated blood back to your heart and lungs so that it can be reoxygenated and recirculated. However, some of that interstitial fluid gets picked up by this green system here. This is your lymphatic system, which collects plasma and waste. This lymphatic system is part of your immune system, and it monitors plasma for infections and foreign invaders. It cleans your body of waste or toxic substances, and then returns clean, inspected plasma up near your heart and dumps it back into the bloodstream to maintain your fluid volume and your blood pressure. That's important to know. Pay particular attention to the capillaries and the lymphatic system here. Now we're going to move on, and we're going to talk about compartments a little bit. Both of these pictures are showing the exact same thing here. And this is showing the compartments in your lower leg. The same concept applies to your entire body though. You can see in your calf, you have 4 major compartments. One to the front of your leg, one to the outer side, a large one in the back, and one in the center. You've got your bones in there, and then you can see that your arteries, nerves, and veins are within this connective tissue that separates it. And this connective tissue is your fascia, and it wraps around all your muscle fibers and kind of keeps it in one coherent unit. And it's important that you understand what this looks like, because we're going to be talking about what happens when you have an increased amount of pressure within these compartments, and what that does to the tissues in there, what that does to the vessels, and what that does to the nerves. So it's important that you understand what this looks like, so that when we're talking about an increase in intracompartmental pressure, you can know that there's fluid buildup within these compartments that are surrounded by a connective fabric. Okay? With all of that out of the way, now let's actually start talking about this hypothesis. I have melded these 2 papers together, but most of the things that I have pulled are direct copy-pastes from their papers. I am going to simplify it with the voiceover, but the text itself is pretty much remains the same. I haven't edited it much, if at all. Most of it is completely untouched. In some areas, I have compressed it a little bit, but for the most part, this is a very accurate representation of exactly what they are saying in their paper. Okay, let's get started. Within a 2-year period in the 1940s, 2 Boston physicians published dramatically opposing views on the underlying nature of the syndrome now known as complex regional pain syndrome. In several papers in 1946 to 1947, Evans suggested that sympathetic reflexes maintain pain and dystrophy in affected limbs. Evans' hypothesis established the nomenclature for this syndrome for 60 years, and his term, reflex sympathetic dystrophy, guided clinical treatment and research activities over that same period. In 1947, Foisy suggested that arterial vasospasms were key in the etiology of this pain syndrome. Foisy proposed nomenclature was unrecognized and had virtually no impact on the field. However, recent evidence suggests that Evans' contribution to the field may have in fact led clinicians and researchers astray for all those years. So let's talk a little bit more about Evans' hypothesis. In 1946 to 1947, James A. Evans, a physician in Burlington, Massachusetts, reported on patients' intense suffering combined with features characteristics of what he called stimulation of the sympathetic, namely rubor, pallor, a mixture of both, sweating, and atrophy. In a series of 4 papers that described at first 32 and then a total of 57 patients, pain was described as deep, boring, diffuse, but with trigger points, and manipulation or use aggravated the patient's suffering. Importantly, Evans reported that often pain in these patients was relieved by sympathetic blocks as the limb warmed. Evans attributed the pain to abnormality of the sympathetic nervous system and first used the term reflex sympathetic dystrophy. Evans suggested that excessive afferent nerve inputs associated with injury initiated central nervous system activity that spread throughout an internudical pool of hyperactive spinal neurons that stimulated sympathetic neurons. Now that is a mouthful. So what are they actually saying there? Evans is proposing that in your peripheral nervous system, which is the system that is out throughout your body, your sensory aspect of that is firing excessively associated with an injury. This excessive firing in the peripheral nervous system sensory aspect causes central nervous system sensitization at the spinal cord, and that this hyperactivity in the spinal cord neurons stimulates your sympathetic nervous system. The activity generated by the sympathetic system was proposed to induce arterial spasms and ischemia, which is the reduction of blood flow to the point where it is inadequate. Ischemia and the spasms increased capillary filtration pressure with resultant edema and swelling. 1 year after Evans coined the term reflex sympathetic dystrophy, Philip S. Foisy, a surgeon at Boston City Hospital, concluded that persisting low-grade arterial spasm after a soft tissue injury can lead to a syndrome with severe pain, extreme tenderness or allodynia, tissue swelling, muscle atrophy, bone osteoporosis, joint stiffness, and limited motion. Basically, the constellation of symptoms that Evans would diagnose as reflex sympathetic dystrophy, Foisy termed traumatic arterial vasospasm. According to Foisy, subacute undetected arterial vasospasms led to a decrease in nutritional blood supply that resulted in degenerative changes, primarily in the musculoskeletal system. Foisy was careful to point out that these vasospasms were not in the large vessels that would produce tissue-threatening ischemia, but rather in the small arterioles. This was even more likely in patients with compression injuries that resulted in increased tissue tension, where the microvascular pressure is reduced because of increased intracompartmental pressure. So basically, Foisy's position was that due to spasms in the blood vessels that carry fresh oxygen to the tissues, and an increase in pressure in the compartments, fresh blood was not making it to the tissues, which was starving them of oxygen and allowing for a buildup of waste and toxic products, which we will talk about further. This results in degenerative changes, mostly in muscles, but also affecting skin, bone, and nerves. This is not in the large vessels, which would produce compartment syndrome, acute compartment syndrome specifically, but rather in the smaller vessels, so it is easy to overlook and can be much more prolonged because it is not an immediate threat within the next several hours. Although, like Foisy, Evans identified arterial vasospasms and capillary permeability as key factors, it was their emphasis on sympathetic nervous system activity that differed dramatically. For Evans, increased activity in the sympathetic afferents, which is the motor aspect, was crucial to the maintenance of the vicious circle, and hyperactivity in the spinal cord maintained the reflex sympathetic drive. However, for Foisy, it was the nature of the injury itself that initiated the vasospasm, particularly in cases where injuries increased the intracompartmental pressure, and sympathetic blocks were seen as a way to overcome the vasospasm. Evans' conclusions were almost universally adopted, whereas Foisy's were almost completely ignored. Emphasis on the sympathetic contribution to reflex sympathetic dystrophy has been a large driver in both the predominant therapeutic practices and mechanistic research activity for the past 6 decades. Symptoms of CRPS include spontaneous pain, such as burning pain in the skin and aching pain in the deep tissues, and a variety of stimulus-evoked abnormal pain sensations, including mechanohyperalgesia, which is an extreme pain reaction to a mechanical stimuli that is only mildly pain-inducing, mechanoallodynia, which is an extreme pain reaction to a mechanical stimulus which is normally not pain-inducing, cold allodynia, which is an extreme pain reaction to cold that is normally not pain-inducing, and sometimes heat hyperalgesia, which is an extreme pain reaction to heat which is normally only mild to moderately painful. Other symptoms include disorders of vasomotor and pseudomotor regulation, which is your vasculature and sweat output, trophic changes in skin, hair, nails, and bone, and dystonia and other motor abnormalities. CRPS type 2, causalgia, is similar in all respects except that there is a clinically verified nerve injury present. The role of the sympathetic innervation in CRPS1 is not well understood. Until recently, it has been generally accepted that most, if not all, of the ancillary symptoms of CRPS1 are due to a hyperactive sympathetic outflow to that painful region, and that the sympathetic outflow is somehow causally related to the pain, meaning that the hyperactive sympathetic nervous system is causing the pain directly. It is generally believed that there is a time progression of symptoms in CRPS1, resulting in 3 broadly defined stages of the disease. The first stage is typified by hyperemia, which is excessive blood flow, and edema, which is swelling. The second stage is typified by being cold to the touch, hyperhidrosis, which is excessive sweating, and cyanosis, which is that blue tinge to the skin. The third stage is typified by dystonia and dystrophic changes. There is evidence that this temporal progression is not present in all patients. Recent discouragement with the sympathetic nervous system as a therapeutic target and an underlying pathology had no doubt encouraged the taxonomic change from reflex sympathetic dystrophy to complex regional pain syndrome, and it has been argued that the former syndrome name may have misguided research and treatment since its inception. The sympathetic innervation may contribute to early stages of CRPS1, but the underlying pathology evolves from sympathetically maintained pain to sympathetically independent pain. A first important finding is that sympathetic blocks do not always relieve pain in CRPS patients. Some patients have remarkable but often short-lived responses, others do not respond at all, and still others respond only following multiple blocks. However, since many of these trials lack control subjects, the gradual improvement over time may reflect the natural history of the syndrome rather than the use of sympathetic nerve blocks. These findings lead to two possible conclusions. One is that the pain of CRPS depends on the sympathetic nervous system in some patients but not in others. Or, two, that the sympathetic nervous system is not critical to pain in CRPS but may influence pain by affecting other crucial factors. And I want to discuss this one a little bit more. This is not to say that the sympathetic nervous system has no role in CRPS, but is it the root source? That is the question. And this is what we're going to be discussing further in this video. A second important finding is that numerous investigations have now reported that sympathetic activity is actually blunted, which means it is reduced, rather than enhanced, particularly in the early stages of CRPS when the limb is hot and swollen. This finding leads to the important conclusion that CRPS cannot depend on enhanced activity in sympathetic motor fibers, at least not in stages during which the activity is blunted. It also supports the theory that late-phase CRPS, when the limb is often cold and cyanotic, may depend on denervation hypersensitivity of sympathetic vasoconstrictors, a phenomenon that would be expected if sympathetic activity is blunted for prolonged periods. What is denervation hypersensitivity? Let's say you have 5 nerve endings, and due to damage and degeneration and starvation of oxygen, 3 of those are called back. They're no longer functioning. They're dead. You only have 2 nerve fibers left. Those 2 fibers would become hypersensitive to make up for the others that are no longer functioning properly. That is what they're talking about here. A third critical finding is that many CRPS patients have subtle but convincing evidence of persistent tissue ischemia in skin and particularly in deep tissue. This is supported by functional observations of increased density of perfused vessels, lower capillary filtration capacity, arteriovenous shunting, and ischemia of peripheral subcutaneous tissue. Now, we're going to start getting into some much more medical jargon here, so I'm going to try and break this down. If I pronounce things incorrectly, that's because I do a lot of reading, but haven't had a formal education, so yeah, take that with a grain of salt. Okay, so the lower capillary filtration capacity means it's harder for things to get outside of the blood vessels into that interstitial space so that the tissue cells can get fresh oxygen. Arteriovenous shunting is when arteries connect to veins and create new connections without capillaries. So you end up having fresh oxygen going straight into the veins and getting diluted with the deoxygenated blood that is already in there. And it just goes right back up to be recirculated and reoxygenated. But the areas that are being shunted over, where the capillaries are blocked, are not receiving fresh oxygen and waste is not being removed. And then again, that ischemia, that is the reduction of blood flow to the point where it is insufficient. There are also functional observations of a high arterial flow, but low oxygen consumption with a high lactate flux, which is indicative of tissue ischemia despite having an increased flow in the large vessels. There is also functional observation of impairments of high energy phosphate metabolism in muscle tissue, suggestive of mitochondrial oxygen deficiency. And I will probably come back and do another video on phosphate, which is totally not related to the content of this particular hypothesis, and I haven't actually seen this hypothesis anywhere, but basically I'm going to come back to this one, so we're going to put a pin in that and move on. Evidence of microvascular injury in the skin, including hypertrophic, multilayered, and sometimes collapsed endothelial cell walls around arteries and arterioles. There is also evidence of reduced skin nutritive flow and capillary hemoglobin oxygenation. Basically, the tissues aren't getting what they need to be healthy and functional. Foisy suggested that traumatic arterial vasospasms take place when increased tissue tension occurs after increased vascular permeability and an accumulation of interstitial fluid, meaning that the capillaries are letting lots of things out and the plasma in that interstitial space is increasing the tension in the tissues and the compartment. He further suggested that arterial vasospasms cause a prolonged arterial inadequacy or an oxidative malnutrition, which results in degenerative changes in the musculoskeletal system primarily. This means that injuries that produce enough edema to increase the intracompartmental pressure can result in microvascular changes and injury that depend on both the degree and the length of time of the increased intracompartmental pressure. I'm going to talk a little bit about acute compartment syndrome. When you have pressures of about 70 millimeters of mercury for at least several hours, this produces the phenomenon known as acute compartment syndrome. Although prolonged intracompartmental pressures of 40 to 45 millimeters of mercury are typically a warning sign of this syndrome. This results when pressure from excessive interstitial fluid within the closed anatomical compartment compresses small blood vessels and blocks oxygen supply to the tissues for several hours or more. The ischemic tissue, particularly the muscle, eventually degenerates, producing toxic metabolites that lead to systemic inflammatory response syndrome and multiple organ dysfunction. This is characteristic of Crust syndrome and tourniquet shock. However, intracompartmental pressures much lower than those needed to produce acute compartment syndrome also have significant effects on microvascular function. Thus, intracompartmental pressures between 25 and 35 millimeters of mercury can block the arterial flow in smaller arterioles and venules. Stepping even further than that, lower intracompartmental pressures of 12 millimeters of mercury can produce a 50% reduction in the number of perfused capillaries, reducing nutritive blood flow to the involved tissue. Normal pressure within a compartment is usually between 0 and 8 millimeters of mercury. Reduction of intracompartmental pressure by as little as 4 millimeters of mercury can restore capillary flow. In a significant number of capillaries, capillary flow can be blocked, causing ischemia, and reestablished, causing reperfusion, with very small changes in intracompartmental pressure, at levels that are much lower than those required to cause acute compartment syndrome. Edema, swelling, develops due to the extravasation outside of the blood vessels and accumulation of plasma in the interstitial space. In the early stages of CRPS1, there is plasma extravasation outside of the blood vessels, increased density of perfused vessels, and higher capillary filtration capacity, which means lots of fluid is leaving the blood vessels and sitting in the interstitial space. The authors of this hypothesis propose that a compartment-like syndrome is created by the period of extensive edema. CRPS1 nearly always follows an injury to deep tissues, but subtotal or episodic or exertional ischemia leads to a compartment-like syndrome that does not progress to tissue necrosis. Following the return of blood flow, there is a short period of swelling and excessive blood flow, followed by neuropathic pain, leading to mechanohypoalgesia, mechanoallodynia, and cold allodynia. Nearly all subjects have no sign of nerve injury from the initial event. Some have a small number of degenerating myelinated axons, reducing the density of the sensory fibers' terminal arbors in the epidermis of the injured limb. This can lead to that denervation hypersensitivity we were talking about earlier. Microvascular pathology that is indicative of the capillary slow flow, no reflow, which we will talk about soon, poor perfusion, and reduced density of viable capillaries for a week following reperfusion. This causes spontaneously discharging A beta, A delta, and C fibers in every case. Your A and C fibers are nociceptive pain neurons that fire in response to damage. We, the authors of this hypothesis, propose that the fundamental cause of pain is persistent, deep tissue ischemia in muscle, bone, and nerves, and consequent inflammatory reaction produced by microvascular pathology subsequent to an ischemia-reperfusion injury. While the proposed compartment-like syndrome does not produce tissue necrosis, it does produce microvascular injury. Ischemic tissues accumulate oxidative enzymes. Upon reperfusion, where the blood comes back, the accumulated oxidative enzymes reduce the returning molecular oxygen, and the cells composing the microvessels are exposed to high levels of oxygen-free radicals that damage both vascular endothelial and smooth muscle cells. Ischemia-Reperfusion injury is a multifactorial phenomenon characterized by several pathological mechanisms affecting arterioles, the small arteries, capillaries, microvessels, and venules, the small veins, creating positive feedback loops that perpetuate and worsen the ischemia-reperfusion injury. It is proposed here that ischemia-reperfusion injuries also occur in microvasculature of bone and peripheral nerves. Ischemia-reperfusion injuries are so named because of the recognition that most of the damage that occurs following prolonged lack of blood flow occurs after the tissue receives blood again, a discovery that was made 3 decades after Foisey's paper. Ischemia-reperfusion injuries are produced by the generation of oxygen-free radicals and pro-inflammatory cytokines, which are messenger cells, which produce both microvascular dysfunction and additional ischemia-reperfusion injuries in neighboring tissues, including muscle, bone, and skin. All tissues, including muscle, bone, and skin, within the occluded, blocked area, suffer the same consequences, although bone and skin are more resistant than muscle. Ischemia-reperfusion injuries initially produce increased capillary and post-capillary venule permeability, leading to extensive plasma extravasation and edema. All that basically means is that ischemia-reperfusion injuries cause lots of swelling. Occlusion, which means blockage, of capillaries generates the phenomenon known as slow flow, no reflow, characterized by the swelling of microvascular endothelial cells, platelet aggregation, and plugging of the capillary lumen, which is the hole, by leukocytes and erythrocytes. Those are white blood cells and red blood cells. Slow flow refers to the condition where the lumen, the hole, is partly occluded, which is blocked, and complete blockage is no reflow or no flow. The smallest capillaries are formed from a single endothelial cell, and their lumen diameters are nearly the same size as the shortest diameter of a red blood cell. This means that red blood cells must deform and squeeze through the capillary lumen. As well as occurring in skeletal muscle, slow flow, no reflow also occurs in nerves capillaries, and it likely also occurs in the outside of bone as well as the inside of bone capillaries, and in cutaneous, which is skin capillaries. The body system responds with attempts to compensate via reactive hyperemia, which is excessive blood flow, and arteriovenous shunting, which is again that connection of arteries to veins without capillaries in the middle, just so the blood can keep moving, but it's not actually distributing anything. High arterial flow, yet at the same time elevated venous pressure, and arteriovenous shunting. Likely due to the slow flow, no reflow in the affected capillary bed, the alternation between ischemia and reperfusion provides a way to spare tissue from lethal injury, but it also creates a vicious cycle of ischemia-reperfusion injury, which maintains the microvascular dysfunction. Skin capillary hemoglobin oxygenation is lowered and skin lactate is increased in CRPS1 limbs, suggesting that there is both impaired nutritive blood flow and enhanced anaerobic glycolysis. Nail bed capillary flow is decreased, so you might notice that your nails are blue or purple or white instead of the healthy pink. And reactive hyperemia, which is that excessive blood flow in cutaneous skin vasculature, is impaired. There is also impairment of high energy phosphate metabolism, and plasma extravasation is exaggerated. Ischemia-reperfusion injuries cause a persistent inflammatory condition. This causes an increase in lipofuscin deposits, which is responsible for wear and tear, atrophic fibers, and severely thickened capillary basal membranes in muscle and subcutaneous tissue. Serum levels of CGRP and bradykinin are elevated in venous drainage as well. In muscle, an ischemic state would be expected to be a direct cause of nociceptor discharge and nociceptor sensitization due to acidosis. Tissue acidosis associated with increased lactate causes muscle pain. Mechanical allodynia is directly correlated with lactate levels, and pain in CRPS1 is increased during exercise. This would be related to the anaerobic respiration. In anaerobic respiration, you are not using oxygen to create ATP. You are instead creating lactate. So in aerobic ATP production, you are creating 30 to 38 molecules of ATP per glucose molecule. In anaerobic respiration, you are only producing 2 ATP per glucose molecule. It also causes lactate to be released. And if you are doing this all of the time, because you're not getting enough oxygen, you're going to end up with increased lactate levels, which can, because of the low pH, cause acidosis in your tissues. CRPS pain feels like inflammatory muscle pain. Differential activation of the sympathetic vasoconstrictor reflex, which is your sympathetic nervous system, causing your blood vessels to get tighter as a reflexive response to muscle and skin, shows that the response in muscle, rather than skin, causes the greatest pain, consistent with ischemic muscle being the primary cause of CRPS1 pain. Prolonged ischemia of bone has been shown to produce bone inflammation and injury. CRPS1 patients often have late-phase periarticular accumulation of tracer, consistent with Ischemia-Reperfusion injury-induced injury to venules leading to intramedullary plasma extravasation. This is inside the bone shaft. The abnormality may not be confined to periarticular bone, the outside, as believed, but may affect the bone shaft as well. CRPS1 patients over time reveal an early hyperperfusion of bone that is followed later by a hypoperfusion. Osteoporosis is an expected consequence of impaired medullary perfusion. All of the observations noted above are likely results of edema, ischemia, and inflammation secondary to slow flow, no reflow, and periosteal and intramedullary microvessels. It's around the bone and in the bone. Ischemia in bone would cause deep, aching pain. In sum, these mechanisms would be expected to cause a persistent, deep, aching pain sensation. It is our experience that CRPS1 patients often insist that their bones hurt. CRPS1 patients frequently, and perhaps always, report the presence of deep, aching pain, and they also commonly report that movement worsens their pain, as would be expected if their muscles were ischemic and inflamed. Endoneurial capillaries, which are the capillaries around neurons, are also prone to the slow flow, no reflow phenomenon. Small distal nerves, which would include things like your hands and feet, would be particularly vulnerable simply because they have few capillaries. And if your few capillaries end up getting blocked, then you don't really have other options to compensate for it. There is shown degeneration of intraepidermal nerve fibers in CRPS1 patients, which aligns with neuropathic pain. No flow in the capillaries of small distal nerves might account for such degeneration. Endoneurial ischemia and inflammation would be associated with increased levels of pro-inflammatory cytokines that are known to produce neuropathic pain. Ischemic and inflammatory states within the peripheral nerve should produce spontaneous ectopic discharge in sensory fibers. Ectopic discharge is present in A fibers and in C fibers. Ectopic discharge in nociceptors due to endoneurial microvascular pathology, meaning spontaneous firing of pain receptors due to problems with the microvessels that go to the nerves, would cause spontaneous pain referred to the tissue innervated by the nociceptors within the nerve. Such pain is properly categorized as neuropathic, while the pain from the ischemic and inflamed muscle and bone is not. We, the authors of this hypothesis, propose that both inflammatory and neuropathic pain mechanisms are present in CRPS1. Deep tissue C-fiber nociceptor discharge and ectopic discharge of CH fibers traveling within the ischemic and inflamed nerves will initiate and maintain NMDA receptor-mediated central sensitization. Side note here, if you get ketamine infusions or have a compounded topical ketamine cream, the NMDA receptors are what the ketamine is targeting in response to C-fiber discharge. Input from muscle C-fiber nociceptors is a much more potent initiator of central sensitization than input from cutaneous, skin level, C-fiber nociceptors. Injecting inflammatory agents into the skin produces allodynia that lasts at most hours. The same injections into muscle produce central sensitization and cutaneous allodynia lasting up to several weeks. We hypothesize that the central sensitization evoked by deep tissue nociceptor discharge is the primary cause of cutaneous allodynia and hyperalgesia. The presence or absence, severity, and spatial extent of cutaneous hypersensitivity might thus be expected to vary from patient to patient and from time to time, depending on fluctuations in the intensity of deep tissue pain. If soft tissue injury and inflammation is severe enough to cause a temporary, hours-long, increase in intracompartmental pressure that occludes capillary blood flow, a microvascular ischemia-reperfusion injury will occur. These microvascular injuries would then be expected to produce sustained hypoperfusion, which means blood not getting out, and reduced nutritive blood flow. Importantly, since this is most likely to occur in deep tissues, the ensuing ischemic changes may go undetected. Ischemia-reperfusion injuries produce significant arterial vasospasms or enhanced vasoconstriction, which is the contraction of blood vessels, due to microvascular dysfunction associated with increased responsiveness of smooth muscle adrenoceptors to the sympathetic transmitter norepinephrine, and a reduced production of the endogenous vasodilator nitric oxide. The main cause of arterial vasospasm or enhanced vasoconstriction following ischemia-reperfusion injury is the dramatic loss of nitric oxide, much of which is scavenged by increased oxygen-free radicals to produce nitrogen-free radicals. Thus, arterial vasospasms can be maintained after the ischemia-reperfusion injury, even if sympathetic activity is blunted or reduced. If you would like to learn more about reactive oxygen species or reactive nitrogen species, also known as free radicals, I have more on that in my source sheet. Following ischemia-reperfusion injuries, the arterioles' endothelial cells release less nitric oxide, and the reduced amount of nitric oxide that is released is then converted to toxic nitrogen-free radicals after interaction with oxygen-free radicals. The result is a deficit in the nitric oxide-mediated vasodilation, which is the expansion of blood vessels, that normally modulates the vasoconstriction that is evoked by the sympathetic nervous system. Meaning, when the sympathetic nervous system is activated and your blood vessels get tight, nitric oxide is then what is released later to allow the blood vessels to become a more loose, dilated size for increased blood flow. CRPS1 patients have abnormal vasodilation responses after sympathetically evoked vasoconstriction and decreased levels of nitric oxide. Endothelin-1 production and release are increased, and so is the vasoconstrictor, the tightening of blood vessels, response that it evokes. There is an upregulation of endothelin A receptors, which are responsible for vasoconstriction, as well as enhanced sustained nociceptive behaviors following the release of endothelin-1. This stimulates fibrosis and reactive oxygen species and cytokine production. There is also an upregulation of the expression of alpha adrenoceptors on arterial smooth muscle cells, resulting in a 3-fold increase in the contractile response to norepinephrine. This means that arteries will spasm in response to normal levels of sympathetic discharge, which is known as vasoconstrictor tone, as well as to a myriad of sympathetic reflexes that are evoked by daily activity and in enhanced arterial responsiveness to catecholamines such as epinephrine and norepinephrine that arrive in circulation. In addition to this, reduced sympathetic outflow itself results in a hypersensitivity of smooth muscle adrenoceptors to norepinephrine, as well as increasing and enhancing painful responses to norepinephrine. Remember how we were talking about that denervation supersensitivity, where you had 5, but 3 go away, and you're left with 2, and those 2 are trying to do the work of 5. When you have this sympathetic activity that is blunted at the beginning, you become more sensitive to the results of sympathetic activity to make up for that. The major sympathetic neurotransmitter is norepinephrine. So due to the hypersensitivity of the reduced sympathetic outflow, you are 3 times more sensitive to norepinephrine. And so when the sympathetic activity starts to resume a more regular occurrence after that blunted period at the beginning of CRPS1, you are 3 times more responsive to the levels than a standard individual. This means that sympathetic activity would definitely be contributory to CRPS pain, but it is not fundamentally causative. Vasospasms in pre-capillary arterioles, which means contractions in the small arteries before capillaries, exacerbate the ischemia, contributing to the maintenance and worsening of the ischemic state. Slow flow, no reflow in deep tissue microvasculature would be expected to produce a persistent inflammatory state. Lactate, or lactic acid, is also increased in muscle and further elevated during exercises. There is a direct correlation between mechanical allodynia and lactate levels. Allodynia also depends on the generation of oxygen-free radicals and pro-inflammatory cytokines. Free radical-induced lipid peroxidation was significantly elevated in CRPS1, suggesting a key role of free radicals. Free radicals and cytokines generated by ischemia-reperfusion injuries trigger neutrophil, which is a type of white blood cell, recruitment and adhesion, leading to capillary plugging and endothelial cell swelling and the eventual collapse of the capillary lumen, which is the hole in the center that things move through, leading to a phenomenon called capillary no reflow. This results in arteriovenous shunting and a significant reduction of nutritive blood flow within the affected capillary bed. Free radicals damage capillary endothelial cells and stimulate them to release various pro-inflammatory mediators. Many of these molecules are chemotaxic, which means they move in response to extracellular signals. They recruit monocytes, leukocytes, and platelets, which accumulate and occlude the capillary lumen. They release TNF-A, interleukin-1, and interleukin-6, which produce toxic effects that might spread tissue injury to adjacent regions. Free radical damage to endothelial cells of venules resembles that seen in capillaries, which causes the leakage of plasma through the resultant gaps between the adjacent endothelial cells. It is significant that plasma extravasation occurs mostly at the level of the venules, not the capillaries. Free radical damage to the venules is the immediate cause of swelling formation. Initially, this produces enhanced vascular permeability, allowing things to cross, that contributes to the damage causing vasospasms. But as the vasospasms progress to no reflow, plasma extravasation is diminished, as there is a reduced blood flow within the microvasculature. This shift from initial high plasma extravasation to later capillary no reflow could explain why many CRPS patients start out with significant swelling, but then progress to a state with less swelling and more ischemia. Later capillary no reflow may also explain why CRPS is less likely to respond to antisympathetic treatment with greater time following the syndrome onset, as antisympathetic treatments likely relieves vasospasms but not capillary no reflow. The initial duration of the swelling stage of CRPS1 is highly variable. Some patients remain in this state, some have episodes of exacerbated swelling, and some progress to a non-swelling stage characterized by cyanosis and atrophy of the subcutaneous tissue. Patients with slow flow would be expected to exhibit edema, but there can be no plasma extravasation from leaky venules if there is no reflow from their upstream capillaries. Thus, at later times, when no reflow predominates, the patient would be in a cyanotic or atrophic phase. We, the authors of this hypothesis, propose that the progression from early stage to late stage CRPS1 reflects the evolving dominance of no reflow over slow flow in deep tissue capillaries. The variability in the progression from predominantly slow flow to predominantly no reflow is likely to be the basis of the argument over whether CRPS1 is a staged condition. Ischemia in the swelling stage of CRPS1 is likely to be due primarily to the slow flow and arterial vasospasm. Sympathetic activity, whether normal, increased, or decreased, would significantly reinforce arterial vasospasm and worsen slow flow, thereby increasing ischemia and pain. Interruption of the sympathetic outflow to the affected region would relieve the arterial vasospasm, increase capillary flow, and decrease pain. Such patients would be classified as having sympathetically maintained pain. However, Prolonged ischemia would likely lead to the gradual accumulation of capillaries with actual no reflow. Sympathetically mediated arterial vasospasms would make little or no contribution to the downstream blood flow if the capillaries are already blocked. The patient would thus be unlikely to benefit from interruption of the sympathetic outflow to the affected region, meaning the patient would have sympathetically independent pain. Thus, we, the authors of this hypothesis, propose that the transition from microvascular slow flow to no reflow is the basis for the transition from sympathetically maintained pain to sympathetically independent pain. Vasospasm is a likely consequence of a traumatic injury to a major nerve because major nerves travel alongside a large artery and a vein, which is known as the neurovascular bundle. In CRPS2, we, the authors of this hypothesis, suggest that injury to the neurovascular bundle evokes arterial vasospasm and initiates tissue ischemia and subsequent slow flow, no reflow in deep tissue microvessels. The end result is the same as the Ischemia-Reperfusion injury evoked by the compartment-like syndrome in CRPS1. For many years now, the cutaneous skin level manifestations of CRPS1 have been the primary focus of investigation. We, the authors of this hypothesis, propose that as an underlying mechanism, cutaneous pathology may be of decidedly secondary importance. We propose instead that deep tissue pathology, endothelial dysfunction, and persistent ischemia and inflammation in muscle, bone, and peripheral nerve is the key to the syndrome's pathophysiology, and we suggest that the deep tissue pathology is driving the cutaneous abnormalities. We are not the first to suggest that deep tissue pathology may be of fundamental importance, but we have proposed a distinct and testable hypothesis for its cause. The proposed damage to endothelial cells and associated vascular leakage through post-capillary venules and the role of leukocytes and neutrophils in plugging capillaries leading to no reflow suggests that pain associated with CRPS1 may be alleviated both by anti-inflammatory drugs and by novel agents that inhibit endothelin, leukocyte, and neutrophil attraction and migration and platelet aggregation. Alpha adrenoceptor antagonists may be effective, especially in early-stage CRPS1, since they would prevent the enhanced vasoconstriction evoked by norepinephrine from the sympathetic postganglionic neurons, or norepinephrine and epinephrine from the circulation from acting on upregulated smooth muscle cell alpha adrenoceptors. Symptoms may also be alleviated by treatment with nitric oxide donors or other vasodilators. Relief of deep tissue ischemia may underlie the beneficial effects of hyperbaric oxygen therapy, spinal cord stimulation, and physical therapy. The key role of free radicals and cytokines after ischemia-reperfusion injury suggests that antioxidants, free radical scavengers, and anti-cytokine drugs may be useful. We, the authors of this hypothesis, have not extended our hypothesis to account for the motor abnormalities that occur in CRPS1. We have not accounted for the deficits in the somatosympathetic reflexes that characterize CRPS1. We have also not accounted for the occurrence of CRPS1 following stroke. Our hypothesis does not address the question of why CRPS1 symptoms sometimes spread to the contralateral extremity. However, contralateral symptoms are common in response to muscle afferent activation or muscle inflammation. We suggest that the neuropathic component is due to ectopic nociceptor discharge. CRPS1 is accompanied by changes in the central nervous system regions that regulate somatosensation, motor control, and the autonomic nervous system. A role for central nervous system mechanisms as a consequence of the peripheral pathology described here is not a contradiction. We propose a hypothesis that we believe is relevant to at least a subset of CRPS1 patients, and perhaps also to CRPS2 patients. We do not claim that the pain mechanisms that we describe are present in all CRPS1 patients. CRPS1 may be a term that encompasses pathophysiologically distinct conditions. That is a lot. So, what are the 7 major takeaways from this? Ischemia-reperfusion injuries resulting in oxygen starvation and reactive oxygen and nitrogen species. Arteriovenous shunting, creating new connections from arteries to veins without capillaries, where oxygen is not transferred and waste is not removed. Anaerobic respiration. I'll have another video on this, getting more in detail on that. But where only 2 ATP are produced per glucose molecule instead of the 30 to 38 that would be available in aerobic respiration. An increase in lactate due to anaerobic respiration, which leads to acidosis. Ectopic nociceptive discharge from the A and C fibers, leading to central sensitization via NMDA receptors, causing allodynia, hyperalgesia, regional neuropathic pain, and reduced stimuli thresholds. Tissue degeneration of muscle, bone, skin, and nerves. And hypersensitivity to norepinephrine via upregulation of alpha adrenoceptors, leading to a 3-fold contractile response to norepinephrine from normal levels of sympathetic nervous system activity, from normal levels of sympathetic reflexes, and from sympathetic hormones in circulation, as well as enhanced pain responses to norepinephrine. That was a lot, and it was pretty in-depth. I hope you were able to follow through with that with me. I hope it made sense to you. I hope it expanded your understanding of CRPS. Thanks so much for watching. You're welcome to share anything on my channel. If you like what I'm doing here, hit subscribe. If you'd like to contribute to my medical expenses, my Patreon is linked below. As always, relevant sources are linked in the description. Again, most of these sources are more secondary explanations of things that they talk about in their papers, and I've just let their own works cited sheets be their support for their hypothesis. Okay, I think that is everything. Thanks so much for sticking with me. I hope you learned something today, and I hope to see you next time.